Thank you for the invite, Andrew. You guys can see the slides?
Yeah, we can. Thanks.
Right. Okay. So I was asked to talk about TB meningitis, and specifically the diagnosis, management, and outcome of the condition. But let's see if I can move it. Sorry, I just have trouble moving the.
Jim, if you can't move it, just stop sharing and then just reshare it. Sometimes does that.
Okay, let's see if that works.
Are you still sharing? So
I'm just trying to. There we go.
Now.
There we go. Okay, it's working. Thanks, guys.
Great.
So right, if you look at the diagnosis, I think I like this slide because it shows to make that diagnosis, you need to complete a jigsaw. Very important to take a proper history, especially in relation to if there's household contacts with TB. You need to examine your patient properly, which I'm sure all of you do as clinicians. And then you've got this range of investigations, in most cases available in low resource setting, to help you confirm the diagnosis. And just some clinical pointers, which I find very useful. One is that the onset of tuberculous meningitis is often insidious, and we often talk weeks instead of days. I think that's important to appreciate because that emphasizes that there are always opportunities for early intervention, which is of critical importance, especially if you want to ensure a good outcome. Then that the early symptoms are often non-specific, and that is why it's very challenging, especially for us to diagnose TBM early. And most patients that we see have stage 2 and stage 3 TBM, in other words, advanced TBM. And I think that is because of the fact that the symptoms, especially in the young child, are non-specific. They may simulate general viral infections, but an important diagnostic clue is that there's persistence of signs. And that is not always appreciated because these children, especially in the periphery, get seen by different clinicians, and there's not appreciation of persistence of signs. Then also neck stiffness is not something that we often see in young children, especially early disease. So most of the TBM stage 1s, which you want to diagnose, they don't have meningism. So don't think that absence of meningism equals absence of TBM. And then especially because this seminar is on raised intracranial pressure, it's important to appreciate that vomiting without preceding nausea should alert you to the possibility of raised intracranial pressure. And that's often not appreciated. And I always tell my students that vomiting without diarrhea is not gastroenteritis. Think about intracranial pressure. Right, as Llewellyn has alluded to, important to look at the road to health chart. In most cases, there is evidence of weight faltering. We do tuberculin skin testing in children under the age of 5 years to see if they're sensitized to TB, and most of them will be, unless you've got overwhelming disseminated disease or unless you're HIV infected. Then the skin testing is not always helpful. Then in all cases, we do chest x-rays, both AP and lateral, and we also do that in the caregivers. Because the last thing you want is to have a mother sitting in your ward with cavitating TB disease and exposing everyone to the risk of tuberculosis. And we find it very useful. The mothers wear a mask when they're sitting with their child, and we do sputums and chest x-rays in mothers that we are concerned about. As you can see on the AP, we often see lymphadenopathy. Studies have shown that in children with TBM, about 50% of cases will have radiological evidence of pulmonary tuberculosis. And if you have a TBM patient with HIV, that goes up to 80%. So it is well worthwhile doing chest x-rays. And obviously we do AP and lateral, and we look for the donut sign, highlightenopathy, airway compression, and see if there's miliary patterns. Then we proceed to do CSF sampling, as Llewellyn has suggested, first CT scan, and then we lumbar puncture the child. In TB meningitis, then often not that many cells. I think that's something that I've learned over the years. So if you have thousands of cells, it's more likely septic than TB meningitis. What we also find challenging is that the findings of your CSF in TBM is not always typical. In fact, the majority of cases are atypical. And I've seen cases of TB meningitis with normal cell counts, actually no cells in the CSF. I've seen cases with normal protein, normal glucose, and also cases of CSF neutrophil predominance, and especially in the child with early TBM. And it can become very challenging if you work in an area which is TB endemic, because in some cases there is diagnostic uncertainty, and you don't want to put a child who doesn't have TBM on 6 months or 9 months of treatment. And you also don't want to miss treating a child who has TB meningitis. So what we do is, if you're not certain about the diagnosis, we repeat the lumbar puncture in 10 to 14 days. And this is a study that my colleague Regan has done, showing that the CSF and TB meningitis, most of the parameters, they remain abnormal 2 to 3 weeks later. So it's a chronic meningitis, whereas if you have a viral or a plain bacterial meningitis, in most cases, the CSF would be normal after 10 to 14 days, unless it's complicated. So I think that's a very useful thing to do. There's something about the gene expert, which has been very helpful, because we know that cultures take 2 to 3 weeks. So if you want to have a confirmed diagnosis early on, I think that's where gene expert is very important. It also tells you whether your patient has rifampicin sensitivity. The problem with the gene expert is that it's very specific, but the sensitivity isn't that great. So you cannot use it to exclude a diagnosis of TBM, and in many cases of TBM are gene expert negative. If you want to increase your diagnostic yield, both culture and using gene expert, I think it's important that you send adequate samples, volumes to the lab. And studies have shown that 6 mils and higher, if permitted, is better than sending a mil or 2 mils. Then with regard to imaging modality, I think CT is most often done because it's after hours, it's rapid. And I think CT is more than adequate for you to show there's hydrocephalus, to show whether there's basal enhancement if you use contrast. If you have large infarcts, CT can also show that, as well as granulomas, but MRI is way superior, especially if you're looking for brainstem infarcts or thalamic infarcts. And what we often do is, if we have a child who's severely obtunded and has a normal CT scan or no infarcts, then we know it's probably good to do an MRI scan, because the child may well have brainstem involvement. With regard to antimicrobial treatment, this was a study that was published more than 20 years ago, and it's still valid. And what the study reported is that the trials looking at antimicrobial treatment in TBM, all these trials had limited power, poor methodology, and variable treatment results. So it was impossible to assess what is the most appropriate treatment for children with TB meningitis. And I'm embarrassed to say that this is still the case 25 years later, but it may change in the near future. The 2 most common regimens that are used to treat children is the WHO regimen, which is over 12 months. And as you can see, the 4th agent that they use is ethambutol. And then there's a Cape Town, or actually Stellenbosch, Tygerberg regimen, where we've been using for the last 20, 30 years. We've been using a 6-month intensive regimen. And the 4th agent of our choice is Ethionamide. And then there are studies ongoing at the moment, looking at also second-line agents, and most often is levoflox, because one of the things you want is good CSF penetration, which ethambutol and streptomycin isn't. The reason why we've been using ethionamide is firstly because it has very good CSF penetration, better than ethambutol and streptomycin. The second advantage is that if you're dealing with INH monoresistance, you also overcome it by giving this intensified regimen that we use. The complications that we do encounter with ethionamide is that it can cause gastric irritation and vomiting, but we overcome that by giving the ethionamide at night and the other 3 medications in the morning. We don't have the problems of ototoxicity or optic toxicity related to the other fourth line agents. And Regan and myself, we were also involved in this publication, where basically we compared the WHO regimen to the regimen that we use in the 6-month regimen. And basically what the WHO concluded is that both regimens are equally effective, and therefore they also recommend that the 6-month regimen that we propose can be used as an alternative to the WHO regimen. Trials that are ongoing at the moment, I think there's one of the things people are looking at is to see whether if you increase the dose of rifampicin, whether that brings about improved outcome. There was an adult study which showed a marked reduction in mortality when they doubled the dose of rifampicin. We're not sure if the same applies to children, and this study will hopefully give us the answer. Instead of ethambutol, they're also now using levofloxacin to see if that brings about improved outcome because of the superior CSF penetration. Another study, which is called SURE study, once again comparing the WHO regimen to the 6-month shorter intensified treatment regimen using levoflox as well. And what is interesting about this study is that the patients will also be randomized into 2 groups, with or without aspirin, to see if there's any benefit from the anti-ischemic, anti-thrombotic, and anti-inflammatory effects of aspirin. Right, so if you have a child who has tuberculosis meningitis, these are the complications that you will encounter. There's raised intracranial pressure, vasculitis, which causes stroke, ischemia, infarcts, and then you've got the so-called RS phenomena of patients developing mass lesions or having inflammation, especially of the optic nerve. What we do routinely in our patients, if the CT scan shows hydrocephalus, we do an air-encephalogram. It's quite a simple procedure where we inject 5 to 10 cc's of air during a lumbar puncture, and then we do a lateral skull X-ray within 6 hours with the patient in a slightly elevated position. And it's very helpful because it tells us whether you're dealing with a communicating or a non-communicating hydrocephalus. We've done studies showing that CT itself is not useful. There's no markers on CT which is definitive. So that's why we deem this procedure as being the gold standard. So this is an example of a child who has non-communicating hydrocephalus. You see the air bubble sitting at the base of the brain or the prepontine cistern, and there's absolutely no air visible in the lateral ventricles. So if we have that scenario, we know this is non-communicating, and this is a patient that you would refer for neurosurgical intervention. A much more often encountered scenario is that of communicating hydrocephalus. And as you can see, the arrow indicates there's this air bubble right up in the lateral ventricle of the brain, and that indicates that you're dealing with communicating hydrocephalus. And if it's communicating, then these patients will respond to medical therapy, and we treat this with giving Diamox and Lasix. You have to give decent doses of acetazolamide because you have to inhibit 99.7% of the enzyme carbon anhydrases. So just giving a whiff of Diamox is not going to have a useful effect. This is a study that I did as part of my PhD, also using transcranial Doppler. And this was 16 consecutive patients with communicating hydrocephalus. And as you can see, we did lumbar CSF monitoring on day 1, 3, and 7. And as you can see, some of these patients had very high pressures, more than 50, when we did opening lumbar pressures. And all of these patients normalized quite rapidly, most of them within 3 days, all of them within 7 days. So it's our experience that this is quite a majority of patients, more than 90%, will respond to medical therapy if it's communicating. So this is the diagnostic algorithm that we use at Tygerberg. We do a CT scan. If that confirms hydrocephalus, then we decide whether to do an air-encephalogram or not. The child that you would not do an air-encephalogram on is a child with signs of brain dysfunction or impending herniation. So this is a child that we have a rapid decline in the level of consciousness. We have a Glasgow of 13, and then if an hour or two later it's 8, that's a child you're going to refer to the neurosurgeons as early as possible. The child with neurogenic hyperventilation, the child with decerebrate posturing, and the child with absence, doll's eyes. Those are the childs you would not do a air-encephalogram because of the risk of annihilation. All the others, I would do an air-encephalogram. I spoke to Jan Skuman earlier this week. I asked him about Glasgow Coma scale. He says, doesn't look at that. I asked him about unequal pupils, and he said he told me that suggests there's an infectious exudate over the oculomotor nerve. So even unequal pupils would not, he would still do an air-encephalogram in that setting. So if you do air-encephalogram, you'll find that approximately 80% of your patients will have communicating hydrocephalus, and you are able to medically treat them. And as I've said, in most cases, the pressure will normalize within 1 week of therapy. In 10%, around about 10%, these patients may not respond. In that case, you can do repeat imaging to see whether the hydrocephalus has progressed. In some cases, if the child remains deeply obtunded, then it's more likely ischemia-related, brainstem infarction-related. And in those patients, you would offer palliative care and intervention level 2. Whereas if the hydrocephalus have worsened and the pressure remains elevated, obviously that's the patient that you're going to refer for urgent neurosurgical intervention. Probably the biggest challenge that we face in TB meningitis is the treatment or the prevention or the to try and diminish the vascular ischemia, the infarcts, the strokes. And this is where host-directed therapies come into it. And these are the ones that where we've done randomized controlled trials. We've looked at whether prednisone works. There's been quite a few studies now using prednisone or dexamethasone, and that's become standard of care, both in HIV-infected and in uninfected patients. The problem with corticosteroids is that it reduces mortality, but not morbidity. There has been studies using aspirin. The study that my colleague Johan did showed no improvement in outcome or survival. There have been studies from India which showed that it does reduce the risk of stroke in the children with severe TBM. But the results are still inconclusive. There's not enough evidence to recommend it as standard therapy, and hopefully the SURE study will give us sort of better indications as to whether we should add aspirin to our treatment regimen. And then there's been studies on thalidomide, which Johan started and I continued with, and I'm going to show you some of the results there. So why host immune therapy and why is it important? Well, because most of the neurological sequelae, the vasculitis, the mass lesions, they are driven by a sort of a hyperinflammatory response. And we now know that there are many cytokines involved, but the most important ones are tumor necrosis factor alpha, interferon gamma, and vascular endothelial growth factor. And these are publications from us, from our institution. And what we've shown on histology and immunohistochemistry is that the tumor necrosis factor alpha is a very important cytokine to target and to modulate. This is an example of brain histology. This is a vessel showing vasculitis, thickening, and you can see there's a stain, and there's lots of tumor necrosis factor alpha around the vessel, causing inflammation and then narrowing, ischemia, and stroke. And the same for these mass lesions. This is a patient who had a TB brain abscess, and you can see once again at the capsule or the periphery of this lesion, there's a lot of tumor necrosis factor alpha, and that's something you want to try and modulate. So what we've found is that it's very useful to, in these patients with complicated TB and those patients with mass lesion, MR imaging is very informative, and especially if you look at T2 imaging. Because if the lesion, this is a patient who's got a large lesion in his TB mass lesion in his cerebellum, causing ataxia, threatening to obstruct the fourth ventricle, already causing hydrocephalus. So what we look at is we look at how dark this lesion is. And if it's dark, that's good. We want it to become black. And if it's dark, then we say it's most likely a granuloma or Gumma. And we know this is the histology sample of a Gumma, not the specific one, but another patient. And you can see it's very much rubbery. And there are no bacilli in this lesion, and you won't be able to grow anything from it. So this is, in fact, a sterile lesion. And this entails a good outcome if you have that. I think this is a patient actually died from a motor vehicle accident, not from the lesion itself. This is a sample that Richard Hewlett gave me from UCT. This is the problematic lesion. If the T2 lesion is bright or hyperintense, and this represents an abscess. And if you're going to drain it, this is what it looks like. You get pus. And this pus is teeming with TB bacilli, and if you're going to do gene expert on it, it's likely to be positive. And this represents an unsatisfactory immune response. And these patients often have a fulminating cause. And this is where you would consider using thalidomide. We've been publishing our results now for the last few years. We've probably treated more than 50 consecutive patients now with these lesions. And if you can't get hold of thalidomide, another way of targeting tumor necrosis factor alpha is to give the monoclonal antibody called infliximab, which is probably easier to obtain and cheaper than thalidomide. So what we've seen, this is a patient that we've medically treated. This patient came with severe ataxia. He had an abscess also in his cerebellum, as well as a smaller abscess. On T2, it was bright. So in other words, this represents an abscess. And then we're on treatment, what you can see is happening, it becomes a rubbery ball. You can see there's loss of T2 signal, and it becomes dark. And we stopped treatment after, we had thalidomide for 3 months. We stopped treatment after 6 months. And then we just did MRIs at 10 months, 31 months, and 45 months. And this child is completely well. She's playing hockey or netball. And you can still see this rubbery nodule in her brain. But in contrast with a pyogenic abscess, there's no scar tissue. It's nicely healed, and the patient's completely asymptomatic. This is another child who came to us with a spastic paraplegia. On imaging, once again, we saw these lesions in the spinal cord. We started thalidomide because this patient was not responsive to antituberculous or steroid treatment. And then over time, as you can see, there's loss of T2 signal. And once again, the lesion becomes darker and gummatous. And this child ended up from having a spastic paraplegia to walking to running. This is a patient, another example of an HIV-infected patient from Somerset Hospital, had been on high-dose steroids, cushingoid, antituberculous treatment, second-line agents, unresponsive because of these multiple abscesses in the spinal cord. And then after we started giving thalidomide, these abscesses disappeared. Another complication, a nasty complication that you may get from tuberculous meningitis is that the vision is threatened because of what we call optochiasmic arachnoiditis. And this scan, you can see thick inflammatory exudate, which covers the brainstem, it covers the optic chiasm as well as optic nerves. And this is classically the patient that presents during the acute phase, often on steroids with fixed dilated pupils. And if you do fundoscopy, there's pallor of the optic discs. And in these patients, you need to give thalidomide as soon as possible. And we've probably treated about 15 patients that had this complication, and it's also been used in India especially, and we're able to salvage vision in all our patients. You can see this young man is riding his bicycle and is looking at the camera. So we're able to obtain normal vision in this patient by using thalidomide. Does thalidomide work to reduce infarcts? Because that's one of the things we want to do. We know that about 25% of patients that when we start treatment, they develop further infarcts. And that's something we want to try and stop and prevent. And there's, at the moment in India, there's a trial ongoing looking at whether thalidomide can reduce the risk of further infarcts and sort of salvaging the penumbra in some of these patients with ischemic lesions. It probably will work. This is just our experience. You can see this is a child that's admitted with TB meningitis. You can see on the sagittal view, there's a lot of information around the vessels, a lot of contrast enhancements, and this is post thalidomide where these vessels clear up. So we are hopeful. We haven't done a trial specifically looking at whether it works against vasculitis, but we are confident that it may improve outcome. Right, and then lastly, fluid management in TB meningitis, about 85% of patients with TB meningitis will have hyponatremia. Most often, this is related to cerebral salt wasting. The key message is for you not to restrict fluid. Restriction of fluid should not be done in any child with meningitis. It's actually harmful. It may exacerbate cerebral ischemia by compromising brain perfusion. It may also precipitate, especially in TB meningitis, cerebral venous thrombosis. So never fluid restrict these patients. And this is a treatment protocol if you're dealing with hyponatremia. If it's mild, you can just review the hydration status and see if it goes down further. If the serum sodium is below 130, consider it to be moderate, and then you need to correct intravenously slowly by giving hypertonic saline solution. Lastly, something about the outcome in TB meningitis. As you all know, if the patient comes into your ward, we do a staging system. What we've done at Tygerberg is we've decided to use a refined system because we thought that the stage 2 was too broad. So we've now introduced a stage 2A and 2B. What we found, and this is from my study, is obviously the earlier you diagnose, the better the outcome. And with regard to motor outcome, once you've got a patient who has stage 3 TBM, and you've got a high risk of cerebral palsy and death as well. And a large percentage of patients will have quadriplegia. And the same applies to the IQ. With every stage, the IQ drops. You will find that there's a drop in IQ of approximately 10 points. So it emphasizes if you want to have a good outcome, diagnose early and treat aggressively. This is a study, quite interesting study that we published last year, looking at all our patients with TBM, probably over 30 years. And we looked at the outcome. And we looked at no infarcts, which obviously had the best outcome, which you can expect. And then we looked at if there's a difference between right or left-sided infarction and bilateral infarction. As you can would have assumed that if you have infarcts in both hemispheres, the outcome is poorer. Quite interesting is that it's probably better to have infarcts in your right hemisphere than left. And that's because the language domain is situated in the left hemisphere. And then lastly, this is a publication that was published last week, is that your treatment and your management of your TBM patients doesn't end when you discharge them. There's many factors that you need to consider after you discharge them. And this is a very nice publication in this month's International Journal of Tuberculosis and Lung Disease, not only looking at TBM, but also looking at other forms of TB, and just to showing what is important to ensure well-being of these patients. And then the last slide, just to conclude, the best way to improve outcome and survival is early diagnosis. Many of the sequelae that we see, especially the ischemic sequelae, is because of the dysregulated host immune response. And hopefully in the future, we will be able to identify better host-directed therapies to improve outcome. And what is good news is even after years of neglect, we now have trials in childhood TBM, and probably I think within the next year or two, we'll be able to tell you what is the optimal treatment regimen, antimicrobial treatment regimen for TB meningitis, based on the fact that we now will have randomized controlled trials to assess efficacy. Right, that's all. Thank you.